Hi, in this video we're going to talk about basic dysrhythmias, atrial dysrhythmias. So let's refresh our information about the cardiac conduction system. We know that electrical impulses should start at the SA node and they should be conducted down to the AV node. From the SA node to the AV node is where we get atrial depolarization. This is when we have contraction of the atrium. We measure that as the PR interval, and that should be 0.12 to 0.20 seconds. When that stimulation goes from the AV node down the bundle branches to the Purkinje fibers, the ventricles contract. We measure that as ventricular depolarization, contraction of the ventricles represented by the QRS complex. That should be less than 0.12 seconds. In today's video, we're going to talk about atrial dysrhythmias. So when we think about the atrium, we know that that is where electrical impulses should be conducted from the atrium to the ventricle. So if there is an atrial dysrhythmia, something is going wrong in the atrium, and that will affect what's going on in the ventricles. So dysrhythmias are usually classified by the site of origin, such as atrium or ventricle, and how it affects the heart's rate and rhythm. They can be benign or life-threatening, and those that are life-threatening are usually due to decreased cardiac output or tissue perfusion. Let's look at our gold standard again. Sinus rhythm using the 5 methods of assessing and interpreting an EKG strip. During a sinus rhythm, we look at the rhythm. Is it regular or irregular? We are measuring the distance between R to R throughout our entire strip. Is the rate 60 to 100 beats per minute? We're going to count the R's in the strip simply because this is the contraction of the ventricles. When the ventricles contract, this is when it is pumping blood up the aorta and out to the rest of the body. The P waves, is there one P wave for every QRS, and is it upright and rounded? What is the PR interval? The PR interval from the beginning of the P to beginning of the QRS is what we're measuring in the contraction of the atrium. So the beginning of that contraction to the beginning of where the ventricles were contract. And then the QRS complex should be narrow, less than 0.12. That is ventricular contraction. So those are the 5 things we're going to look for in each of our complexes that are identified on our rhythm strip. So let's get started. The first dysrhythmia we'll look at is called a premature atrial contraction, or it can be called an atrial premature complex, or atrial premature beats. For our reference, we'll refer to it as a PAC, a premature atrial contraction. Now, if I told you that something was premature, what would you think? You would think that it came early, and that's exactly what this atrial contraction does. It comes early, earlier than we would be expecting. So in a PAC, we are looking at complexes that look just like the other complexes, but they come early. A PAC is describing an early contraction, but above that, we also need to know, in addition to, is there a PAC, an early complex, what is the underlying rhythm? So in this strip, we can see if we look at the complexes, if we were to measure the complexes, they would be a sinus rhythm, except the 2 that I've circled here come earlier in the strip than they should have. So especially in those 3 middle complexes, we can see that they are distanced equally apart. If we were to take the ones that are circled and move them a little bit later, then this would totally march out as a sinus rhythm. But those two that I've circled just occurred earlier. So the SA node fired earlier than it should have. What this means is in the atrium, in addition to the SA node firing, there is something else that's generating electrical activity. And we like to call these bullies. So this area in the atrium has become irritable. And in that irritability, it is firing as well. So the underlying rhythm of sinus rhythm is coming from the SA node. These two early complexes over top of that SA node are also firing from an irritable place in the atrium. Therefore, we have two that have come early. So when we measure out the rest of the characteristics, PACs will look just like the rhythm that they are occurring with. So we may have a PAC with a sinus rhythm, a sinus bradycardia, a sinus tachycardia. You can even have a PAC with things like AFib and aflutter, but for our purposes, we're only going to be looking at PACs that occur with another sinus rhythm or a sinus dysrhythmia. The exact cause of PACs are not clear, and they're not necessarily life-threatening. They can occur due to a person's age or too much caffeine, or they can occur related to a kind of a warning sign that the irritability in the atrium could extend on to other dysrhythmias. So they're definitely something we need to monitor and to record, but we're not necessarily going to treat PACs unless that patient becomes symptomatic. So these may be something that a person doesn't even feel, maybe on the tele monitor or on a Holter monitor, that little flutter, or maybe not even a little flutter, is shown in a PAC. Here's other PACs. So again, let's look at, we're marching out the 5 characteristics that we're going to be looking at. Is the underlying rhythm regular or irregular? So for our purposes, we can look at this rhythm and start on the left and try to march out, measuring between R to R's. Is there an equal distance? Well, there are going to be 2 instances in this strip that I can tell are not going to measure out. But if we were to take that complex and scoot it over just a little bit, then they would measure out exactly the same rhythm throughout the entire strip. So in this, we could again circle those complexes that came early, but otherwise look exactly like their underlying rhythm, and describe them as premature atrial contractions. How do we know that they're premature atrial contractions? They come early and there's a P wave. Remember, the P wave is indicating an atrial beginning to this complex. So the complex is early. The underlying rhythm is regular. The rate of the rhythm is how we're going to count the R's. Now, if in a premature atrial contraction, I do want you to count that complex in your heart rate number. But what we're going to do is we're going to count it as if it occurred in the regular place within this strip. So let me show you for an example. If this complex here were to occur at an equal distance from this complex as it did the one before, we would actually march it out, and this complex here would occur a little bit later. So when we count the heart rate, we're going to count it in the space it should have occurred. Similarly with this complex that occurs early, if it were the same distance apart as these, then it actually would occur right about here. Why is this important? Because Some of these may, if we stretched it out at the same distance, it may put that complex off of the end of the strip. If it moves that complex off the end of the strip, we don't count it. So let's count the complexes in this strip. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So this one actually has 11 complexes. It would be a heart rate of 110. So it would be sinus tachycardia with 2 PACs. So for the P wave, it's premature, and it always will have a P wave. Again, atrial contractions have a P wave. Our PR interval will be normal, our QRS will be are normal, and so again, PACs come early, but that complex looks just like the other complexes that are in the rest of the strip. Can you identify the PACs in these strips? I'm going to let you take a look. We have 2 different strips here. Again, we can look at the strips and kind of try to measure out and look at what is the pattern. This is kind of like identifying a pattern. What's not right in this pattern? So if we look at the top strip in the first 2 complexes, we can analyze that complex. We can say among these, is the rate regular or irregular? If we just counted the spaces between R to R's, we would have to say it was irregular because there is one complex in the top strip that does not occur in equal distance from either of the R's on either side. But if we exclude that single complex, the rest of the strip will be equally distanced between R to R. So, can you identify the PAC? The PAC in this complex occurs right here. It comes early. If we're measuring R to R and R to R, these distances will be the same. But if we then try to measure the R to R here, it should probably occur right about here. So if we move that complex in our mind right to here, it should equal out to the same distance to this one, and then these, and then these, and then these. So it would be regular, except for this complex here. We have a regular rhythm. What's the rate? Let's count the R to R's, or excuse me, let's count the R's. We have 1, 2, 3, 4, 5, 6, 7, 8, 9. So the heart rate is 90. Remember, no, I'm sorry, I think I counted too many. 1, 2, 3, 4, 5, 6, 7, 8. The heart rate is 80 because if we take that complex that came early and we just scoot it over to where it should be, we're going to count that the one time. So that's 80 for the heart rate. If we were to measure the PR interval, it would be 0.12 to 0.20, and the QRS is narrow and would measure less than 0.12 seconds. So let's look at the bottom one. Can you identify a pattern, and can you identify that there are 2 in the bottom strip that are actually premature? So which of the complexes occur prematurely? In the bottom strip, we have complex number 2, and then we also have this complex down here, okay? So it would be 1, 2, 3, 4, 5, 6, 7, 8, a heart rate of 80. If we went through our 5 steps, this would be excluding these 2 that came early, a sinus rhythm, and we have 2 PACs. So sinus rhythm with 2 PACs. The next dysrhythmia we'll look at is called atrial flutter, or sometimes it's called aflutter. Remember, we're still talking about there's something going on in the atrium, so that has to do with the P wave. The atria are receiving organized electrical signals, but the signals are faster than normal. Excuse me. So what this is saying is that the SA node is beating really, is sending electrical activity really, really fast through the atrium. So it's coming from one place, it's being sent from the atrium, but when it gets to the AV node is able to block some of those impulses from the atrium, from the SA node. Why would it do that? If it didn't block some of that information that's coming down in this instance, then our ventricles would be beating out of control and we would have very poor cardiac output. So the AV node has a really important job in determining should it let all of the electrical impulses travel to the ventricles or should it block some of them. In this instance, one of the things that we can see in this strip is that there are a lot of P waves. And so the P waves, the atrium, are contracting and beating more frequently than the QRS, than the ventricles. In this one, there's only one QRS for every 3 P waves. So before that QRS, can we see that there are 1, 2, 3 P waves for every QRS? In atrial flutter, we are going to have a regular rhythm. Now again, if you go outside of this video, you will find sources on the internet that say that atrial flutter can be regular or irregular, and yes, it can. But for the purposes of our discussion, we're going to look at atrial flutter being a regular rhythm. The only thing that is different is going to be there are more P's than QRS. There are more impulses coming from the atrium than are being allowed to get to the ventricles. So what we're going to see is a pattern that continues throughout the strip. We can see there are 3 P waves and then a QRS. 3 P waves and then a QRS. So in this video, in this strip, what we see is kind of looks like a sawtooth pattern. So the P waves look really kind of big, and the resulting pulse rate is going to be what we are counting for the P waves and what we're counting for the QRS. So on this strip, I have the resulting pulse rate is around 150, simply because we are counting the P waves. But for atrial flutter, we also count the R waves. So it becomes a ratio of what our heart rate is. In this one, we can see that we have 3 P waves for every QRS. So our P wave, our atrial rate, is going to be about 3 times faster than our ventricular rate. And we're going to go on to look at that in our next slide. So atrial flutter, again, a very specific sawtooth pattern, which means that those P waves look kind of like waves on the ocean, or it looks like, to me, I think sometimes the fin of a shark. So the PR interval would not be able to be measurable because we have more P's than every QRS. But we could measure our QRS and know that it is still the narrow QRS of less than 0.12 seconds. So we have a regular rate, a regular rhythm. We have a regular rhythm. Our heart rate, we're going to have an atrial rate and a ventricular rate. We have more P's than QRS's, and we can't measure the PR interval because we have too many P's, but we can measure our QRS. Atrial flutter. This is when our heart is fluttering. So The atrium are beating faster than the ventricles. What happens is when the atrium are beating faster is it's not giving the atrium time to fully fill up before it squeezes down into the ventricles. So we do have some issues with cardiac output. The atrium are squeezing and squeezing and squeezing when it only has a little bit of blood in it. So what's coming down into the ventricles is not coming at a regular contraction or a regular squeeze from the atrium. Patients can develop symptoms of lightheadedness, fatigue, palpitations, short of breath, chest pain. Again, think about cardiac output. How do we treat this? This is when we may give a medication called an antiarrhythmic or an antidysrhythmic drug. So it actually slows down the rate of the atrium that are beating, and it helps it to coordinate its electrical activity with the ventricle. Antidysrhythmic drugs are things like amiodarone and digoxin, making sure that we are measuring the heart rate before we give those medications. Beta blockers slow down that AV node conduction, so it may slow down some of that atrial contraction and then also slow that ventricular response to it. So again, helping with that antidysrhythmic drug to coordinate that beating of the atrium and ventricle. And then anticoagulants. A flutter has a risk of clotting, not as high as a fib, but think about this. If our atrium are fluttering or they are contracting quickly, some of that blood, again, is not filling up and having a big squeeze. So the blood that is coming into the atrium hangs around a little bit longer than if we let it fill up and had a big good squeeze. We want to make sure these patients are not at risk of blood clots, particularly around that AV valve. So anticoagulants like warfarin or heparin may be started for these patients, especially if this is not an isolated event of a flutter, but it's continuous and the patient is symptomatic. So let's move on to our third atrial dysrhythmia. This is called atrial fibrillation. So now we have moved from the atrium that are contracting more quickly in response to the ventricle as in atrial flutter to now the atrium are not contracting, but they're just quivering. So we can see how this is a little bit more advanced in severity than a flutter. The atrium are just quivering and it's non-coordinated. So this quivering that is being sent from the SA node to the AV node, also in the atrium, in addition to the SA node, we now have bullies that are other areas of tissue in the atrium that are irritable. So they are, in addition, creating electrical responses at the same time as that SA node. It's not regular, it's grossly irregular, which means when we're looking at the rhythm, not only are we going to have multiple P waves for every QRS, but now our ventricles are not contracting at a regular rhythm. So the information that's coming from the atrium to the ventricles is just a quivering. We are not getting a good squeeze of the atrium. What does that mean for the blood? It means that the blood is quivering as well and just dripping down into the ventricles. So the ventricles, with their big good squeeze, are not going to be filled with blood either. So we're thinking about cardiac output again. Look at the impulses that originate in the atrium. If we were to count the P waves, we would have a heart rate of greater than 400. Thankfully, the AV node is doing its job and blocking these irregular impulses as they come and only selectively letting electricity get down to the ventricles to help them to contract. In atrial fibrillation, we have an irregular rate. An irregular rhythm. We can count the rate again by looking at the R waves. Now we understand that the R wave, the QRS, that R wave is going to be the ventricles contracting. So this is actually going to be our pulse rate, what we feel. But keeping in mind that it is affecting the volume of blood and how much blood is going to be in the ventricles when they contract. So the rate is usually very high. The rate for this strip, if we count the R's, we get 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. It's at 100. Atrial fibrillation, even if we're only counting the R waves, can be 100 to 175. So keeping in mind that our heart is beating fast and also that we're not getting a good squeeze of blood from the atrium to the ventricle, our patient could definitely have some problems with cardiac output, but also blood clotting. Think about the atrium quivering. That blood is definitely going to be dripping down into the ventricles, but hanging out around those AV nodes. Again, our PR interval is not measurable. We have too many P's for every QRS, but we can measure that QRS complex and it still will be narrow. Why? Because this is not a ventricular problem. The QRS measures the ventricles and our ventricles are still functioning the way they should. This is another slide that has atrial fibrillation. Again, we can look at the ventricular rate. We can see that the distance between R to R's is irregular. If we're only looking at the ventricular rate, we can say in this slide it's 1, 2, 3, 4, 5, 6, 60, but look at all those P waves. We can say there is more than one P for every QRS. We can't measure the PR interval because there are way too many P's and we wouldn't know what to measure, but we can measure the QRS complex and it's still narrow. So remember, in atrial fibrillation, we're looking at the P waves and the QRS. In that top slide, we can also distinguish between coarse fibrillation and fine fibrillation. If we think about this is describing the P waves, in coarse fibrillation, we're still having some pretty intense electrical activity through the atrium. They're not having a good squeeze, they're still fibrillating or they are still quivering, but it's very active. If those P waves go down to fine fibrillation, we can see that the P waves are less noticeable. That electrical activity in the atrium is slowing down. It is not as active as in coarse. So in coarse, we still have the atrium that are trying to send those the electrical stimulation down to the ventricles. In fine fibrillation, the atrium aren't quivering much at all, so the blood is less likely to get down with any type of squeeze to the ventricles. More risk of blood clotting when we have fine fibrillation, but AFib as a high risk for blood clots. There's multiple foci or multiple bullies that are rapidly discharging in the atrium. There's no organized electrical activity in the atria. Again, not a good contraction. It's just quivering. The rhythm is always irregular in AFib. So if we looked at those R to R's, they're not going to be regular. And then we have to think about what is the rate. Atrial fibrillation that's controlled, meaning that the patient is less likely to have any symptoms related to decreased cardiac output, is going to be a rate about 100 or less than 100. So that's 60 to 100 range. We're still getting a good pumping and beating of the ventricles. But when we get an uncontrolled ventricular rate, which is greater than 100, it means that AV node is starting to wear out and is not able to block all of those atrial quivering from getting to the ventricles. Remember, a ventricular rate that gets over 100 and increases above 100 to like 120s, 30s, 40s is going to decrease our ability to have good cardiac output. So what's the difference in A-flutter and AFib? Well, if we look at the pictures, we can see a difference. Atrial fibrillation means the atrium, the P wave, they are fibrillating or quivering. We can see that it's irregular. In atrial flutter, we can see that we have a regular rhythm. The atrium are still contracting, but they're just contracting more times than the ventricles. So we still have more P waves than QRS, but we have equal amounts of P waves to QRS with a flutter and not with atrial fibrillation. Atrial fibrillation can look different in different strips. Like we said, don't memorize the strip. But looking at this, the first thing I notice is it's irregular. It's all over the place. Those R waves are not the same distance apart. And then if we start looking at our 5 steps, do we have a regular rate? Excuse me, do we have a regular rhythm? No, it's irregular. What is our rate? Well, if I'm counting ventricular rate, I can count the R waves. 1, 2, 3, 4, 5, 6, 7, 8. I can say the ventricular, oh, there's one at the end, 9. We can say that ventricular rate is 90, but then when I get to the P waves, there's not one P for every QRS. So I can't have a PR interval, or I can't measure one, and the QRS is still narrow. So I know that the QRS is normal, the P waves are what is wrong, so it's an atrial problem, and this is atrial fibrillation. Some of the things that can cause it can be problems with oxygenation, like coronary artery disease, heart failure, valvular problems, not opening and closing correctly, that interrupt oxygen that's feeding the heart muscle. AFib also has increasing risk as we get older and after heart surgery. Like we've said, if they go in with a heart cath and they actually stimulate something in the atrium that they shouldn't. We said there's a high risk for stroke with AFib. A-flutter as well, but AFib in particular. Why? Because the atrium are not contracting, they are quivering, which means that that blood that's coming into the atrium is going to be sitting there, and as the atrium are quivering, it's going to be just dripping down into the ventricles. They spend more time, the blood does, hanging around the bottom of the atrium at those AV nodes, increasing the risk of blood clotting in those areas. How do we treat AFib? Again, we may use an antidysrhythmic. We may use a beta blocker to slow that AV node conduction, slow that ventricular response, help to coordinate that electrical activity. We're going to be using anticoagulants. So if the medication's not successful and the patient continues to have a high rate of AFib, particularly ventricular rate, they may do a cardiac ablation. So a cardiac ablation can be used for different kinds of dysrhythmias, and I'll let you click on that link to look at it. But it's where they go in a procedure and either freeze an area or cauterize an area with heat in the atrium that are creating extra electrical activity. So we talked about those bullies that are in the atrium. If they cauterize that tissue outside of the SA node, it will prevent that area from continuing to stimulate electrical activity. So then let's talk a little bit about anticoagulants. Anticoagulants we can classify them as anticoagulants that are given urgently or emergently. And when I think about that, I think about something that can be given IV or sub-Q. And then when we think about something that's more of a maintenance anticoagulant, I think about that being something that's PO, the patient will take it home. So first let's talk about heparin in our diagram here, or on our chart here. Heparin can be given IV or sub-Q. So heparin is given if we need to have immediate anticoagulation. So if my patient is having a heart attack, or they are coming in the hospital and they are having atrial fibrillation that is very symptomatic. So we could give them heparin in an IV, and it would help to thin the blood immediately going into the bloodstream, okay? Heparin affects the intrinsic clotting pathway, and I'll let you guys look that up. It's a rapid onset of action being administered directly into the bloodstream. Heparin has very few drug interactions. If we're administering heparin to the patient, it has to be administered continuously. So they will have a heparin drip. Heparin doesn't stay in the body very long at all. So if we want to have continuous anticoagulation, that has to be hung in a bag of heparin and run continuously while that anticoagulation is needed. It's eliminated through the kidneys. The antidote or the reversal agent for heparin is called protamine or protamine sulfate. We'll always keep that in our Omnicell or Pyxis or whatever our medication administration system is on our unit. So with heparin, we're going to be looking at certain labs versus warfarin or Coumadin. So let me talk about warfarin or Coumadin for a minute. Warfarin and Coumadin, warfarin is the generic, Coumadin is the brand name. So warfarin it affects the extrinsic pathway. It affects clotting just a little bit differently than heparin on a different pathway. It can only be given orally, so warfarin's a pill. It also has a very slow onset of action. So if I give someone warfarin, it's going to take several days for that blood clotting to start to become active. So if our patient's in the hospital and they need anticoagulation, we're going to put them on a heparin drip, give them heparin, and they will transition to warfarin. So while they're getting heparin, we will actually give them a pill of warfarin, and we will still give that heparin in those days that bridge until the warfarin starts to become active. So usually about 3 days, they may be getting both of them. Once the warfarin starts to work as an anticoagulant, the heparin can be stopped. Warfarin has many drug interactions. It has many food interactions. That has to do with the antidote or reversal agent for warfarin being vitamin K. Vitamin K being in multivitamins, being in foods such as green leafy vegetables and strawberries and sweet potatoes. So people that are taking warfarin have to watch what they're eating and eat a stable amount of vitamin K every day. So we don't usually tell patients that they can't eat vitamin K. Vitamin K is important. It's a clotting agent, and vitamin K is in a lot of things. But what we tell them is their intake of vitamin K should be consistent, because without consistency in their diet and their dietary amount of vitamin K, then warfarin and its ability to thin the blood is going to be like a roller coaster. So if our patient likes to eat salads, they can eat a very small salad a couple of days a week, making sure not to go heavy on the dark greens. But they shouldn't eat a huge, massive salad filled with vitamin D, or excuse me, filled with dark leafy greens full of vitamin K on Monday, and then have nothing else the rest of the week, and then do that again the next Monday. That's going to cause kind of a roller coaster, because warfarin is very hard to regulate because there are so many other factors that can interfere with its ability to clot. So we're going to look at a different lab when we talk about warfarin. This is where we're going to start to talk about PT and PTT and INR. So I'm going to table that for a couple of more slides. Both of these are anticoagulants, which means the purpose is to thin the blood. So patients on both of these are at very high risk of bleeding. How do we monitor for bleeding? Well, we can look overtly. We don't want our patient to fall. We don't want them to have any bleeding around catheter sites. We don't want any bleeding at a surgical incision or a wound. But we're also going to monitor for bleeding in things like bruising, petechiae, black tarry stools, epistasis, which is nose bleeding. We're going to look for blood in the urine, which is hematuria. We're going to advise them to do things to prevent bleeding. Of course, we don't want them to fall, which means if they're using a walker or a cane, this is where we stress you have got to use your walker and cane, because if you fall and become injured, getting a wound, but also hitting your head, that could be very, very dangerous and you could have bleeding. So we want them to use an electric razor versus a straight razor. We want them to use a soft bristled toothbrush. We want them to, if they do have any bleeding, hold pressure on that site, and if it doesn't stop bleeding within 5 minutes, to call 911. They also are going to, if they're taking warfarin, have to have blood work done at least monthly. So they're going to be looking at blood levels. There are food and drug interactions, like we said with warfarin, and falls can be deadly. So let's look at the new anticoagulants. These are called 10A and thrombin inhibitors. So XA is said 10A. It is the clotting factor 10, and A means activated. So types of these inhibitors are rivaroxaban and apixaban. They're developed as alternatives to warfarin because they don't have the interactions with so many things like food and medications. You don't have to continuously have lab work because the clotting ability, the anticoagulation ability in your body is much more stable with these medications. It doesn't fluctuate from day to day with activity and the things that we do. There is a reversal agent for these, and it's called Andexxa. We would use a reversal agent if a patient were taking these and they were in a car accident or they had to have emergency surgery or something like that, to decrease the amount of blood thinning that may be dangerous in one of those instances. We can use different labs to monitor 10A and thrombin inhibitors. We can look at the PT, the prothrombin time, which we'll look at in a minute. We can also measure a 10A factor or an anti-factor 10A to look at the factor 10 clotting to see how this anticoagulation is going. We want to always teach patients on anticoagulants of any sort. Do not stop taking them suddenly. Again, they are on these medications because having a blood clot is a very high risk. So don't stop taking without consulting your doctor. Again, anticoagulants, falls can be deadly. And when taking 10A inhibitors, thrombin inhibitors, any type of anticoagulant, they do not want to take anything else that provides anticoagulation, which means you don't want to take another anticoagulant like warfarin. You don't want to take an antiplatelet medication like aspirin. Heparin is an anticoagulant, and it's also an antiplatelet aggregator, which means it prevents platelets from sticking together. You don't want to take heparin or aspirin if you're taking a 10A or thrombin inhibitor either. And with any of these anticoagulants, you can't take NSAIDs. NSAIDs have a similar component to aspirin, which is an antiplatelet agent. So discontinue any of those before procedures as directed by their doctor. So let's look at the labs. In particular, we're looking at 3 different labs, and these are called PT, prothrombin time, PTT, partial thromboplastin time, and INR, which is the International Normalizing Ratio. So PT and INR assess the extrinsic pathway. So remember when we talked about extrinsic, we said that was warfarin or Coumadin. And so warfarin or Coumadin is measured at the the extrinsic pathway. So we're going to look at prothrombin time. We're also going to look at INR. INR is the International Normalizing Ratio, and it is actually a standardized ratio that reflects prothrombin time. So we're going to look at the time that it measures in seconds for prothrombin time, but then that is equivalated out to an INR number. So when we look at labs, we have to think about what is going on with this patient. Are they on an anticoagulant? If they're on an anticoagulant, we would want their blood to be thinner than someone that's not on an anticoagulant. So what is normal for one person may not be normal for another person. For example, if we're looking at the INR, which is a ratio that is looking at prothrombin time, you or I who are not on any coagulants, we would want, or not on any anticoagulants, sorry, we would want our blood to clot within 1 to 2 seconds. So the INR that's normal for you and I would be from 1 to 2, or sometimes even less than 1. If my patient is on Coumadin or warfarin and we want their blood to be a little bit thinner, their normal INR would be between 2 and 3. So it's taking 2 to 3 seconds to clot, which is longer than it would take you and I. Hence, their blood is thinner. Now, some patients, their rate of warfarin or Coumadin is going to be even higher. So what that means is maybe they're given a higher dose of warfarin or Coumadin. And so that INR may be, the doctor wants it between 3 and 4. So patients that have artificial heart valves. So it would take 3 to 4 seconds for their blood to clot. Anytime an INR is greater than 4, it is a clotting and bleeding emergency. So think that our patient may need vitamin K, again, which is the reversal agent of warfarin, if their INR is greater than 4. It is too thin. Now let's look at PTT. PTT is partial prothrombin time. So partial prothrombin time is measuring heparin. And what I like to think about with PTT is that those T's that come together, they kind of almost look like it could be the bottom of an H. So that reminds me that PTT is a measure for heparin. So we may also see this as APTT, which is activated partial thromboplastin time. So we would want that PTT to be 20 to 35 seconds to measure accurately what heparin should be doing for that patient. Acute or high bleeding, again, if we're giving heparin, we may want to consider the reversal agent of protamine sulfate. We're always going to have vitamin K and protamine sulfate on our unit in our Omnicell or Pyxis or whatever our medication dispensing system is. If a patient is anticoagulated, of course, their numbers are going to be higher because it's going to take more seconds or longer for the blood to clot. So this is an example of labs of a PTT, and INR. So keep in mind that anytime a patient is on an anticoagulant, their PT, PTT, and INR are going to be elevated. What we are looking at in particular is based on the anticoagulant that we're using. So in this lab, it's going to say that all of these are high, which means it's high compared to what the normal for someone not on an anticoagulant is. So our INR is 2.1. It shows the norm range there. We said that if someone is on an anticoagulant, usually we want their INR to be between 2 and 3. So our patient on an anticoagulant, this would be normal for them. Now, usually the physician or surgeon or whoever has ordered the anticoagulant will put a range in our notes that says what range or what parameter they want to keep the INR in order to be able to know that patient is anticoagulated correctly. So if we were to have a patient with an artificial heart valve that they wanted it between 3 and 4, we would know that in our physician notes.